So, good evening, everyone. I'm Dr.Yogesh Harwani, and again, I thank all of you to be here at third clinic of Advanced Gastro Summit 2020. I thank once again Gujarat State Chapter of ASI, Gujarat State Surgeon Association, Association of Physicians of Gujarat, Association of Physicians of Ahmedabad, and Gujarat State Family Physician Association to contribute academically for making this program successful. So today we have Dr. Nilay Mehta, our own senior gastroenterologist from Ahmedabad, who will be speaking on pancreatic space occupying lesions. I would like to introduce Dr. Vivek Tank, who is a consultant endoscopic surgeon at Noble Gastro Hospital, Ahmedabad. I request Dr. Vivek to introduce all chairpersons, and then Dr. Dhiren Bhai, please introduce Dr. Nilay Mehta, sir.
Hello, Yogesh Bhai, can you hear me?
Yeah, I can hear you.
On behalf of Noble Gastro Hospital, I welcome all the participants to the third chapter of the Advanced Gastro Summit. Today's chairperson are Dr. Dhiren Patel. He is a president of Association of Physicians of Gujarat, Director Sanjeevani Hospital, Surat. He is also a member of Ethics Committee, IMA Headquarters, Delhi, and a Secretary of Hospital Boards of India, Surat. He is also a member of the Central Working Committee, IMA Gujarat, past president of IMA Surat, and ex-Senate member, Gujarat University. Welcome, Dhiren Bhai. Another chairperson is Dr. Bhagirath Solanki. He is a professor of medicine at Civil Hospital, Ahmedabad. Welcome, Bhagirath Bhai. Our third chairperson is Dr. Kavesh Patel. He is a senior surgeon in Himmatnagar, Gujarat. Welcome, Kavesh Bhai. I now hand over to Dr. Dhiren Bhai Patel for further program.
Yeah, thank you for kind introduction. First of all, congratulate to Noble Gastrocare for arranging such a nice conference. Now I am introduced Dr. Nilay Mehta. He is a senior and chief gastroenterologist at Zydus Hospital, Ahmedabad. He is a truly academician, and he is really invited as a nationally and internationally as a faculty to share his experience in various conferences. He is expert in endoscopic ultrasound and third space endoscopy. He is really expert in gastro practice. I welcome Dr. Nilay Mehta to educate on pancreatic space occupying lesion, how to evaluate and what to do. This is a common findings in pancreas in patients on USG abdomen and CT scan for both for physicians and surgeons. I welcome Dr. Nilay Bhai. Please. Thank you.
Thank you, sir, for kind words of introduction. I am going to discuss mainly pancreatic head mass because that's what we see normally. Just a minute. Okay, so I'll just start my presentation. This is a 50-year-old man coming to us with upper abdominal pain for last 3 months. Routine investigations were normal. In fact, initially the sonography was done, which was normal. And this patient was treated as a case of dyspepsia, and that is what normally we do when patient comes to you with an epigastric or upper abdominal pain, where the investigations are normal. But unfortunately, this patient persisted to have pain and now started having weight loss and now jaundice. Patient also was detected to have diabetes mellitus during this duration. So the CT scan was done at this juncture after 3 months of illness. And what CT has shown is there is a mass in the head of the pancreas at the genuine head. There is a dilated bile duct and dilated pancreatic duct with an atrophy of the pancreatic body and tail. So basically, this is a case of pancreatic head mass. What is important is it has caused obstruction to both the bile duct and the pancreatic duct. So both are dilated. But what is more important, one should know is in a pancreatic malignancy, you have more atrophy of the body and tail than chronic pancreatitis. So if you have a significant pancreatic atrophy of body and tail, just don't think that this is chronic pancreatitis, even if you are not seeing a mass, because malignancy causes more atrophy of pancreas compared to a chronic pancreatitis. So why sonography was normal? It can come normal in a case of pancreatic malignancy because sonography accuracy is only around 50 to maximum if sonologist is good. If the disease is pretty advanced, then it can go up to 90%, but you can miss easily a mass in sonography. What is important one needs to do is a CT scan, and not just any CT scan, but we need to do a pancreatic protocol CT abdomen, because that will pick up even a small mass. So what does a pancreatic protocol CT abdomen means? It's a thin section, multi-phase technique where you have a plain CT, that is pre-contrast images, and you have an arterial phase, which is early arterial phase, which occurs between 17 to 25 seconds after the start of injection, which will tell us about the superior mesenteric artery and aorta. Then comes the pancreatic phase where the pancreatic parenchyma is opacified, which comes at around 35 to 50 seconds. And then there is a portal venous phase, which comes late around 1 minute. So all three phases are important to delineate a mass in the pancreatic pancreas. If it's a good pancreatic protocol CT abdomen, then the sensitivity of picking up a pancreatic malignancy is anything between 90 to 97%, which is a good sensitivity. And if the mass is bigger than 2 centimeter, then it's almost 100%. But if the mass is small, then even a good pancreatic protocol CT scan can miss a lesion, especially if it is less than 2 centimeter. So CT is absolutely must. Don't rely on sonography if your patient has persistence of symptoms with especially red flags like jaundice or weight loss. You have to do a CT abdomen. That's the message for all my physician and general surgeon friends. So not only CT abdomen is good for diagnosis, it can also tell us about other it can give us other information which is required for therapy of this pancreatic malignancy, and mainly that is surgery if it is resectable tumor. So it will tell us about the vascular invasion, both arterial and venous. In fact, it scores over other modalities as far as arterial vascular invasion is concerned. Good sensitivity, good accuracy, with a good negative predictive value for vascular invasion. And it also is, I'm sorry, but someone has to stop talking on phone while I'm giving a talk, because it causes a lot of reverberation and echoes when I'm talking. Someone's phone is on. Please stop everybody's mic, please. It's a request. And CT abdomen is also used for treatment monitoring. The other feature in this patient, which was important, is that this patient had a history of 3 months and there was a new onset of diabetes. Even with diabetes of a long duration patients, they have a higher chance of around 2-fold increased risk of pancreatic cancer. But when you have a symptom along with new onset of diabetes, you have to rule out pancreatic cancer, because 85% of the pancreatic cancer, they have patient of diabetes. They have either hyperglycemia or diabetes mellitus, and majority will have new onset of diabetes, which is less than 3 years duration. In fact, this new onset diabetes, if the patient has a resectable cancer and you take out the cancer, may revert back, means hyperglycemia subsides. So this is very important. You have a symptom, you have a new onset diabetes, you don't see a lesion on sonography, get a CT scan done, because you are missing a pancreatic cancer over here. Why do they get? It is because of paraneoplastic phenomenon. It is because of adrenomedullin. That's the substance which causes aggressiveness of pancreatic cancer. It also is responsible for diabetes mellitus and insulin resistance. So what another investigation was done? CA99. Unfortunately, this CA99 was normal. So what is CA99? It's a carbohydrate antigen. We know it's a sialylated Lewis blood group antigen. Normally, it comes positive in a pancreatic adenocarcinoma. It doesn't come positive in pancreatic neuroendocrine tumor. But normal CA99 does not mean it is not pancreatic adenocarcinoma, because as I told you, it's a Lewis blood group antigen, and it depends on what the patient genotype is. So if patient is a non-secretor for this Lewis blood type negative, so it is negative, his CA99 will come positive, and that happens in 5% of adenocarcinoma. So normal CA99 does not mean it's a pancreatic malignancy. Elevated CA99 comes positive in mainly pancreatic exocrine and also neuroendocrine. I'm sorry, I said not positive in neuroendocrine, but it is more commonly seen in adeno-CA and less commonly seen in neuroendocrine. That's why but it was a blanket statement which was not right. It can also come positive in other biliary malignancies like gallbladder, cholangiocarcinoma, and pyloric cancer. But what is important is that it can also come high in benign diseases like acute cholangitis. I've seen, in fact, my patient has CA99 like 50,000. I would think more about cholangitis induced rise in CA99 rather than just a malignancy. So I've seen 50,000 without malignancy in a cholangitis case. Another thing what our physician surgeons, they do, oh, let's do all the tumor markers and we get CA99. Problem is it's useless for a screening test. Normal CA99 does not rule out malignancy. High CA99 does not mean it's a malignancy. And we don't know what actually is the real value of CA99, which should be the cutoff to say accurately that this is pancreatic malignancy. But yes, you have a lesion in pancreatic pancreas and you have a high CA99, then chances of adenocarcinoma or a pancreatic malignancy is high. So in a case of biliary obstruction and cholangitis, even without malignancy, CA99 come positive, but you have a mass and you have a CA99 high, it most likely is it's a malignancy. In some centers, CA99 is also used to as an indication for staging laparoscopy, meaning if you have a very high CA99, they would do staging laparoscopy, doing laparoscopy prior to VPUL and see whether this patient has peritoneal mets or not. High post-operative CA99 would tell you that probably this patient has a very aggressive tumor. And if you have a surgery done and your CA99 had gone down, but now again it has coming up, it has started coming up, means you have to rule out recurrence. What about MRI? MRI is not superior to CT scan except two conditions, where you have a very small tumor or isoattenuating tumor, which is not seen well in a CT scan. But otherwise, CT is the way to go. Another indication or another usefulness of MRI is you don't see a mass, but you just see a single stricture in pancreatic duct. Then you have to rule out a pancreatic malignancy. What about PET CT? PET CT by and large is not indicated if on CT it's a resectable tumor. We know PET CT has a wider anatomical coverage. It will tell us about metastasis. But if it is a resectable tumor on CT scan, you don't need a PET CT. Only in case of doubt, you need it. For a local lesion, PET CT is inferior to CT scan because it's a metabolic scan. It has inherently low spatial resolution, means it will not give you good local guidance compared to CT scan. So a PET CT is required only if you are suspecting that this is a metastatic disease or it is an unresectable tumor where you would like to rule out metastasis. So it has a very limited preoperative role, PET CT, in a case of resectable tumor. But yes, once you are treating this patient on chemoradiation, then it's a good investigation to monitor the therapy and to see for the recurrence. What about EUS? EUS is better. Only one thing, and that is small tumor, one, and also venous invasion. This is a pancreatic mass, This is portal vein confluence. SMV goes like this, and you can see there is an invasion of SMV by the mass. You can see very clearly there is indentation and there is infiltration of the mass, which was not shown on CT scan. So basically, the endoscopic ultrasound has two advantages, three advantages. Small tumor, it can be picked up. Second, venous invasion, US is better. And third, you can take biopsy. As you can see, we were taking biopsy by an FNA needle. So all these investigations, why they are required? Because you need to do a surgical staging. You need to find out whether this patient has a surgical resectable tumor or non-resectable tumor. This is absolutely mandatory, and that is usually done by arterial and the venous invasion. I'm not going to go into detail, but someone who has encasement, venous encasement more than 180 degree, arterial encasement is a locally advanced disease. But in between, there is a entity called borderline resectable, where there is abutment to the vessel or the invasion is less than 180 degree. And there you have a role of neoadjuvant therapy. So you give therapy and then you resect this tumor. As I told you, ES is better for small tumor and also in certain tumor like isoatonic tumor. In fact, you can barely see a tumor on EUS over here. Basically, this was an insulinoma, which was not picked up by CT scan because it was an isoattenuating tumor. In EUS, you can barely see, but you can see a tumor over here. We took biopsy, and basically, it was insulinoma. Sometimes CT-MR can miss small mets, and then you can pick them up on EUS. But otherwise, CT is the gold standard. EUS, I told you, is indicated for small tumor, for venous invasion, and also, most importantly, for tissue diagnosis. And the advantage of EUS FNA is not only higher sensitivity, higher accuracy compared to CT FNA, but the most importantly, it is safe. In CT FNA, you are doing it for percutaneous route, so you have a chance of malignant cell needle track. So needle path can be responsible for future metastasis. In EUS FNA, you are doing it from the duodenum, which is otherwise also you are going to take it out in Whipple surgery. So it's safer than percutaneous FNA, and that's why EUS FNA is the way to go in a case of taking biopsy in a pancreatic mass. So take-home message in this case is USG abdomen has a poor accuracy. It can miss the lesion. CT is good for diagnosis, not good only for diagnosis, also to see for the resectability. MRI in US is important compared to CT in a small isoattenuating tumor. US has better venous invasion compared to CT abdomen, and US is good to take biopsy. In fact, it should replace the percutaneous biopsy. I still know that many of the my friends, surgical colleagues, they still go for CT biopsy, not in pancreatic malignancy, not where you can take a US biopsy. CA99 is a good marker, but it's not a screening tool. It can be negative. So negative does not mean it's not tumor. Most importantly, if you have a symptom, suggest you have pancreatic disease and you have new onset diabetes, you have to rule out malignancy. This is a case number 2. This is a 38-year-old man has a past history of chronic pancreatitis, of alcoholic etiology, and now it has come with change in symptoms. So now the pain has gone up and weight loss is there. So any chronic disease, forget about chronic pancreatitis, any chronic disease, you have a change of symptoms, you have to rule out malignancy. So basically this is a CT scan with calcification, dilated duct, and atrophy. And there is a mass in the head of the pancreas. So does that mean it is cancer? We don't know. It could be cancer, or in alcoholic pancreatitis, 2 things you have to rule out. One is inflammatory mass. The other thing is groove pancreatitis, because both can mimic mass pancreatic malignancy in a case of chronic pancreatitis. Chronic pancreatitis patient, they have a 15 times higher chances of developing cancer. The risk at 20 years is around 5%. Most of them, they develop cancer in the head. What are the predictors? Old age, persistence of jaundice, new onset of jaundice, worsening of abdominal pain, significant weight loss, patient develops gastric outlet obstruction or CA99 greater than 300. So that's the indication to rule out whether this patient has a true tumor or a pseudo tumor, which occurs very commonly, especially in chronic alcoholic pancreatitis. Problem is how to investigate, because as you can see, in first case, while CT, EUS were great investigation, here all the investigations, CT, MR, PET, EUS, USFNA, sensitivity is not very high. In fact, it is very low, less than 80%. So which is not good. You can miss malignancy, and it's extremely difficult to confirm sometimes in a case of chronic pancreatitis to rule out pancreatic malignancy. Here, PET is better if the tumor is smaller, but if the tumor is too big in a case of chronic pancreatitis, then sometimes CT can miss it, because there, see, the metabolic activity of a pancreatic mass would go down. So even a large mass in a chronic pancreatitis can be missed on CT scan. US and EUSFNA, traditionally, they have a low sensitivity, high specificity, but sensitivity is low. What helps over here is something called contrast enhanced EUS or elastography. These are the special methods we do it in US, which can tell us about the stiffness about the tissue, which can tell us where to target our needle and take biopsy and rule out chronic pancreatitis. Because you can see here it is 70%, but when you use this contrast enhanced EUS, it can go up to 90%. Problem is EUS fails in chronic pancreatitis. Even the biopsy fails because of many reasons, because chronic pancreatitis is such a disease where sometimes to pass a scope is difficult, to pass a needle is difficult. Pancreatitis in chronic pancreatitis inherently has lobulations, calcifications, which can hide the pancreatic malignancy. And dilated PD in a case of chronic pancreatitis, you know, that doesn't mean that it is related to cancer, because you can also have it because of chronic pancreatitis. So here we have to struggle more. We have to take help of something called contrast enhanced EUS. We have to do more passes. We have to use core biopsy needles, which are available nowadays. And sometimes we, if it's possible, then we have to do genetic analysis. So our patient, CA99 was done, which was 150. USFNA was done twice, which was negative. We thought it was alcoholic chronic pancreatitis with a pseudo tumor. We put this patient on NJ feed because patient was not tolerating orals. Patient's pain subsided. Patient became better symptomatically, and at 6 months, patient was asymptomatic without any significant mass. But what is important is this patient had alcohol abstinence. If your patient has chronic alcohol pancreatitis and patient keeps on taking tobacco on alcohol, he's not going to get better. So take home message in this case is differentiation between true malignancy and pseudotumor is mandatory in a case of chronic pancreatitis. It's easier said than done. EUS, everything fails, but you have to struggle and finally reach a final diagnosis. This is a case number 3, 66-year-old man coming to me with a history of jaundice since 1 month, had associated abdominal pain, epigastric pain, dull, constant weight loss of 12 kg in last 1 month. There was no fever. He had diabetes. He had coronary artery disease. Investigations had shown high bili, high enzymes. USG and CT had shown a mass in the pancreatic head, which was not very well defined. It was ill-defined mass. CA99 was normal. CA was normal. Normal pancreatic duct. Now, when you see a normal pancreatic duct and pancreatic head mass, you have to be extremely cautious, because then saying that it's adenocarcinoma, you have to be cautious in saying it. Neuroendocrine tumor still can have normal pancreatic duct and a pancreatic tumor, but adenocarcinoma usually have a pancreatic duct dilatation, and other conditions which we are going to discuss can have a normal pancreatic duct and a pancreatic mass. So this patient, actually endoscopic ultrasound was also done. EUSFNA was not done because they thought there was a big interposed vessel, and then patient came to us with jaundice. This is MR and CT scan. This is an CT scan which had shown a dilated pancreatic duct and a stricture in the pancreatic segment of the bile duct. Now, this CT should have told us that this is a different etiology. This is not a pancreatic malignancy, because it's just not the head mass, which the radiologist thought over here, but it's a sausage. So it's a very distended kind of pancreas, which is a sausage shape, if you use this thing, and then it's a hypodense ream. This is a classical autoimmune pancreatitis. You can see the date. This is 2010. Now we are very aggressive in ruling out chronic autoimmune pancreatitis. Then in 2010, people were not aware of this entity. But when I saw this CT scan, I was almost sure that this is autoimmune pancreatitis. In spite of CT showing that there is a vascular invasion, in spite of CT and MR showing there is a tight stricture in the head of the pancreas, and then we did EUS. EUS also showed the same thing. There is no mass. It's a bulky pancreas, which was showing pancreatic head mass kind of picture. There was a stent which was done by an ERCP guy previously. You can see a ream in this EUS also. So it's a bulky pancreas, and you can see a ream. So which was hypodense in CT is always hyperechoic in sonography. It's the reverse in CT and MR, CT and sonography. So then we did biopsy. We did IgG4, which was high, 4.52, and this is 2010. You may think, oh yeah, and then we did biopsy, and biopsy showed plasma cytic infiltration, and we also could do IgG4 staining, which was positive. So this was a case of autoimmune pancreatitis. This is a classical picture of CT scan, which we describe. In spite of having the mass, if you see this is autoimmune pancreatitis. In pancreatogram, you can see long stricture, which is not the case in a chronic, either in chronic pancreatitis or pancreatic mass, or you see multiple stricture, but there is no upstream dilatation. This is very classical of autoimmune pancreatitis. The IgG4 related disease, we know it's a systemic disease. It's just not the pancreas. It can also involve bile duct, where you get a primary sclerosing kind of picture, where you have a multiple stricture in the bile duct, either extrahepatic or intrahepatic, or both extra and intrahepatic. You can get salivary gland involvement. In fact, this the disease in old days, when I was doing my residency in 1990s, we used to call it as Mikulicz disease, where patient would have salivary involvement, dry eye, and then now we know that Mikulicz disease is nothing but part of the IgG4 associated disease. They can have chest infiltration. Now we have to be very cautious, because chest infiltration in present days is almost always COVID, and they can involve tuberculous nephritis. The last IgG4 I saw was patient had a obstructive jaundice, patient had lymph node, and patient had a mass lesion in kidney. We took biopsy from the lymph node, IgG4 came negative, but we did biopsy from the kidney, and IgG4 came positive. So it's a multi-systemic disease, and also ulcerative colitis can be associated with that. And this is a cholangiogram, not in this patient, but otherwise you can see PSC-like picture, PSC-like picture. The beauty about this disease is you give steroids and everything will vanish. All the strictures will vanish. And biopsy will show you lymphoplasmacytic infiltration, number one. Fibrosis, which is a classical fibrosis. It's called storiform fibrosis or whirling. So the fibrosis is like whirls, and you see IgG4, and you have to do an IHC, and if it is more than 10 per high power field, it's called autoimmune pancreatitis. And these are the criteria. Again, I'm not going to go into detail, but how to differentiate malignancy with autoimmune pancreatitis, absolutely mandatory. I've seen patients coming to me after V-pulse, where patient had pancreatic mass. At least 2 patients have come to me after V-pulse, surgery done for pancreatic mass, tissue specimen sent, came out as autoimmune pancreatitis. So it was actually autoimmune pancreatitis where patient's V-pulse was done. So all my physician surgeons, don't neglect this entity. If you have a highly suggestive of pancreatic cancer, fine, do surgery. But if you have a doubt, rule out autoimmune pancreatitis by IgG4, by a CT scan. But if you have a doubt, do a pancreatic core biopsy, and we can do core biopsy with EUS. And with biopsy, we can do IgG4, and we can give steroid trial. If patient responds, it's definitely autoimmune pancreatitis. If patient does not respond, then this patient goes for surgery. So don't go for surgery straight away. So this is what happens. You saw that bulky pancreas after course of steroid, pancreas has shrunk. You can see this is what happens. So this is the prior to therapy pancreas. This is after pancreas. So remarkable response to steroid. So take a message, autoimmune pancreatitis is not uncommon, and it is seen in our country. And you have to keep it in mind. If you see a pancreatic mass, but normal pancreas, rest of the pancreas with normal pancreatic duct, if you see a pancreatic mass which is ill-defined, if you see a pancreatic mass with the entire pancreas is bulky, sausage shaped, rule out autoimmune pancreatitis. In case of doubt, take a biopsy. In case of a doubt, give steroid trial. 3 to 4 weeks of steroid, nothing is going to happen. Case number 4. This is a 53-year-old man coming to us with obstructive jaundice. There is a lesion on sonography, and on CT and MR, there is a head pancreatic mass, and you can see a stricture. This is a dilated bile duct. This is the normal pancreatic segment of bile duct, and this is a stricture. Now, this is a head of pancreas, but if you see the stricture, it is in the suprapancreatic segment. Can it happen with pancreatic malignancy? Yes, it can happen with pancreatic malignancy if the pancreatic malignancy is the superior part of the pancreas. But here you have to doubt whether this is pancreatic malignancy or something else. Why? Because the stricture is at the suprapancreatic segment. We did EUS, again early days, 2010, there was a mass in the head pancreatic segment, but if you see carefully, pancreas is here, and the mass is actually compressing the pancreas. This is not a pancreatic mass. The mass, yes, it is invading portovenous confluence, but frankly, this is pancreas, this is mass, they are separate, and this is a necrotic mass. And we did USFNA, and it showed Langerhans cells and granuloma. So it was TB. So in case of doubt, please rule out other etiology. Not all pancreatic head mass are malignancies. It can be something else. So to summarize my talk, and I'm not going to touch upon the pancreatic cystic lesion, because that's basically not for surgeons and physicians. Pancreatic cystic lesions are of 5 types. The few of them are benign, like serous cystadenoma. Mucinous cystadenoma has a malignant potential. SPAN needs surgery, but I think it's too much. And the diagnosis is mainly done on imaging and EUS and SOS biopsy. So I'm not going to touch upon those pancreatic cystic lesion. So my physician surgeon friends, you need to know certain things. If you have a pancreatic mass, you have a doubt, sonography is normal, get a CT scan done. CA99 is not a screening test. You see a mass, do a CA99. CA99 is normal, does not mean there is no cancer. CA99 is very high, it may suggest that it's an aggressive cancer. In fact, you do surgery and still CA99 is more than 180, it's an aggressive cancer. EUS is better for small tumors less than 2 centimeters, and it has superior imaging compared to CT scan if it is small. And it has a better imaging modalities for venous invasion. For arterial invasion, CT scan is any day better. You cannot replace CT scan with EUS. CT scan is a primary modality to investigate, to confirm, to see for the metastasis, to see for the resectability. EUS is an additional investigation where you want to confirm the diagnosis, you want to see the venous invasion, and you want to see the local tumor. PET-CT has a very limited role in pancreatic mass, especially if it is a resectable tumor. PET is not a great investigation. I still do PET-CT if I'm suspecting it's an unresectable tumor, or sometimes I do PET-CT if I'm suspecting autoimmune pancreatitis. Because if I don't have sufficient evidence to say that it is an autoimmune pancreatitis as far as pancreas alone is concerned, Because autoimmune pancreatitis is an IgG4 associated disease, which is a systemic disease, I will see avid lesions in salivary gland, in retroperitoneum, in kidney, other places. When I see those things, I'm almost sure that this is probably IgG4 associated disease, and then I'll try to take biopsy from those spaces. And lastly, not all pancreatic masses are cancer. It can be TB, it can be a cystic lesion, it can be a benign lesion like insulinoma. So just don't say, okay, go for Whipple surgery. You have to investigate properly before you venture into doing surgical therapy. I think I'll just stop over here. And Yogesh, if we have, and my chairpersons, if we have questions, we can discuss those things.
Yeah. Yeah, excellent and very informative talk. Really very good insight about the whole topic of a pancreatic tumor by Dr. Nilay Mehta. He has given very clear-cut guidelines for how to diagnose this case of pancreatic tumor. He has given very good take-home message also. So thank you very much, Dr. Nilay bhai.
Thank you, Dirbai.
Request Dr. Request Dr. Bhagirath bhai to comment, please.
No, it was really an informative lecture for the physicians. But I will have one question, Dr. Nilay bhai. What will be the position of the lipase amylase? Because physicians are only struggling at that level. So in all this condition, I think they would be always altered and high.
Not in pancreatic malignancy. Amylase, lipase, they are significant when they are more than 3 times the upper limit of normal. See, suppose lipase upper limit is 60 and you get 90 lipase, it's not abnormal. Okay. Basically amylase lipase is done when you are suspecting acute pancreatitis. So that if you have a classical pain related to acute pancreatitis with raised amylase and lipase, then it confirms acute pancreatitis. In pancreatic malignancy, very high amylase lipase, then you have to rule out acute pancreatitis, because malignancy also can cause acute pancreatitis. And in old age, in fact, I have one admitted patient right now who has come with acute pancreatitis, but has a tumor actually. Okay. So in those scenario only, amylase lipase would come high.
Thank you.
Thank you. Yogesh, you have to, your mic is off.
Sir, you had mentioned that in those patients in whom we are suspecting autoimmune pancreatitis, we should give a trial of steroids, though they are not confirmed on biopsy or other diagnostic.
Yeah, autoimmune pancreatitis, you need 3-4 things. One is history. Second one is imaging. Imaging is the most important thing. Your CT guy has to be really good. Third thing is FNA and biopsy. We can take core biopsy. Now, if it tells you that this is almost certain this is autoimmune pancreatitis, you don't have a problem. But if it doesn't tell you and still you are suspecting autoimmune pancreatitis, you can give steroid trial. But the mistake we do is we continue with steroid trial for too long. That should not be done. If your patient is not getting better, worsening, there is no point in continuing with steroid trial.
For how long, sir?
I had one patient where USFNA was done thrice, not once, twice, thrice. Twice they had told me that this is malignancy and I did not do a USFNA. But this was a young patient. She had pancreatic head mass, no pancreatic head mass, but CBD stricture, which was not classical of pancreatic malignancy. And I did ERCP, I put a stent, and initially I had to put him on steroid, and I put him on azathioprine for 2 years. And after 2 years, there is no stricture, so stent free. So, but yes, if my patient would have become worse, I would not have waited. I would have told him, go for surgery, hard.
Sir, would you like to highlight role of EOS in therapeutic modalities of CA pancreas?
we have discussed about diagnostic modalities, but
I saw the topic list, and your topic was EUS in malignancy. So I did not touch upon those
no, just
topics.
to highlight today, if you can educate physicians as well as surgeons.
Yeah. So basically, EUS is good for diagnosis, but also it requires to be done in a therapeutic manner. So normally what we do, either we do ERCP, right? And we put a stent because we want to palliate or we want to reduce the jaundice. Now, if the jaundice is more than 15, then you need pre-operative ERCP. But now recent trials have also come that you do pre-op ERCP, give chemotherapy, and then do surgery, and results are better. But normally you do it either for pre-operative or you do as a therapeutic. But sometimes you have a duodenal obstruction, and there you have to resort to EUS because you cannot do normal ERCP. And there you have to either puncture the duodenum or you have to puncture the stomach. I think you are going to show the video. Shall I show them small video or it's okay?
Yeah, you can, sir. You can. Sure.
Okay. So basically this patient had gastric outer obstruction and lower CBD obstruction. So we cannot go there and do ERCP because there is no access to ampulla. So what we did was puncturing the liver from the stomach and do something called Eos Guided Gastrostomy. So basically this is EUS showing liver. This is dilated duct. And then we puncture, this is a cystotome. We pass a wire, there is a stricture, lower end stricture because of C8 pancreas. And now we are putting a metal stent between the left duct of liver and stomach. So basically this is a covered stent which is very long. And we make an anastomosis between the left lobe of liver and the stomach. And since this is a fully covered biliary stent, sometimes we put a double pigtail stent inside the metal stent so that it does not migrate. So now you can see this is basically the left lobe of liver lying somewhere over here. This is the stent in the liver. This is the gastric wall, and this is the stent in the stomach. And because it should not migrate out of the stomach, we have placed a double pigtail stent through it. So that is a way of palliation with EUS. Sometimes we do have D1, which is open to us. In that scenario, we can puncture the first part of duodenum and we can place stent between between the bile duct and okay, there is no MP4. Okay, so again, this patient has, just a minute, I'll just give a brief introduction. So this patient has metastatic disease, but okay, just, and this patient has duodenal obstruction, so we cannot go and put a stent in the bile duct. So this is basically a metastasis disease, and there we puncture from the duodenum. We puncture and then pass a wire into the duodenum, and then we dilate the tract and put a fully covered metal stent between the common bile duct and duodenum, and there is an obstruction at the D2. So this is, and you can see the bile is draining well. Once it is done, you can see a stent between the bile duct and duodenum, and then there is a duodenal obstruction. So after that, you can also put a duodenal stent. So this was duodenal obstruction, metastatic pancreatic malignancy with ascites. So one stent is between the duodenum and bile duct, and the second stent we put is into the duodenum. So now he has bypass of both the bile duct and duodenum. So Yogesh, when we fail in ERCP and there is no access to ampulla, EOS has a definite role to play, not only for the bile duct, also for the pancreatic duct, and I'm sure you are going to discuss it more in your talk. Just, yeah, yeah, please go ahead.
So, Dr. Kavesh bhai, would you like to ask few questions to Nilay sir?
Hi, Nilay. Yes, sir, Majama. We see many times as pancreatitis versus malignancy versus CP, complex picture sometimes. And you rightly mentioned that not a single investigation is the investigation of choice. We have to keep on investing till the patient is not covered fully. I think EOS is very much promising nowadays, because where we are in the residency, we are taught that if it is a pancreatic as well, if it is a resectable, go for resection. I mean, if it is not resectable, give a triple bypass. But I think after EOS...
Actually, after EOS, even PTBD indications have gone down. See, I have nothing against PTBD, and tomorrow only I've asked my radiologist to do a PTBD in one patient. But now we have a very limited role of PTBD. So the problem with PTBD is two-stage. You must have encountered that they first do external drainage, and it is very painful. And then problems like bile leakage and other things, right? And in second stage, they still put stent, and then also after that, they have a bile leakage. EOS has an advantage that it's an internal drainage. It's not an external drainage. And now, because we've become better, we know how to puncture stomach, we know how to puncture duodenum, we know how to place stents everywhere, and it is safe. Generally, it is safe, except hepatogastrostomy. If you land up in a problem, then how you know how to deal with it. But otherwise, no, definitely. And there are now head-to-head trial where efficacy is better, complications are less with EOS drainage compared to PTBD. And triple bypass is absolutely out. You cannot do a surgical treatment for palliation, period. Surgery is for cure. Surgery is not for palliation. Palliation is always have to be a minimal invasive procedure.
Sir, I have a question. There are no symptoms or very mild symptoms in early stages of pancreatic malignancy. So, and usually we see all the pancreatic cancer diagnosed always later stage or terminal stage. So CT scan is the only answer, or what would be the best approach to diagnose early?
You have doubt, get a CT scan done. Still you have a doubt, get an EUS or MR done. So your patient has persistent pain. Forget about weight loss and everything. Persistent pain. Endoscopy is normal. Get a CT scan done. We sometimes underutilize CT scan. And talk to your radiologist. Please see pancreas. Pancreas is such an organ that you miss a small lesion, you miss even a big lesion if you are not done a proper study. Thank you. Bhagirath bhai, you are not audible. You are not audible, no. See, you are talking about something called CA99.
It is not useful, so CT will remain the choice of investigation.
Absolutely,
to rule out.
absolutely.
Sir,
CA19.
yeah. I will have a question. Because we are using all these gliptins, DPP4 and the incrinomimetic drugs here, do you have any such patients coming to you having such
With
pancreatic
pancreatitis.
issues?
Yes, yes, yes. They come with acute pancreatitis. They come with recurrent pancreatitis if physician has not stopped the gliptins.
Okay. But not the malignancy. It's only pancreatitis.
No, not malignancy. No, no, no.
And what about you say about the diabetic patients? It is not applicable to the routinely low onset diabetes patients.
Again, your sound has gone. Again, your sound has gone. You are not
Bhagirath bhai,
audible,
voice
sir.
is not clear.
No, it is clear? No. There is some technical problem.
Now you are audible. Tell me.
Okay. So you said about the diabetes. So whether this diabetes is only in the setting where the patient is having abdominal pain with hyperglycemia, then we have to think. Otherwise, routine type 2 diabetic patients silently diagnosed, it is not applicable, I believe.
No. Recent onset diabetes with symptoms, you have to get it done. Even if sonography is normal. You have abdominal pain, you have significant weight loss. Of course, uncontrolled diabetes also will have weight loss. Yeah.
Any other questions? Dr. Vivek Tang, would you like to ask any questions, sir?
Sir, regarding the palliation, can you tell us something about the Eos Guided Gastroenterology for the CA pancreas?
Yeah. I think it's very expensive to do it. But otherwise, it's a good procedure. I have not done it. US guided gastrojejunostomy, the problems are that if you have a balloon, which is a special balloon tube, then it becomes safer. But freehand technique, you can land up in a big problem. Second thing is stent is very expensive. And third thing is, see, whenever new modality comes, there are always reports that new modality is better. You and I and everybody knows. But still, it's only time will tell whether it is better than luminal stent. Luminal stent is cheaper. It's easier. You can easily go through the lesion and put a stent. Gastrojejunostomy has an advantage that it is not going through the cancer. So chances of blockage are almost nil, while stent can get blocked. That is the only disadvantage. But I still prefer a normal luminal stent compared to gastrojejunostomy for the reasons what I told.
Thank you, sir. One more question from Dr. Smith Kumar, and I quote, if we suspect autoimmune pancreatitis, but by steroids, TB or fungal lesions flare up, how to be careful during the steroid trial?
Yeah, Candida is very common when you give steroids for normally oral Candida comes. Then you just have to give fluconazole. You don't have to do anything else. And sugar during steroid, if it is around 200 or less than 200, you don't have to treat. Hyperglycemia secondary to steroid, you have to be cautious in being aggressive. Bhagirath bhai will tell us more, but that's the way we keep on checking sugar, which is for a short time. So it's fine. You can always give steroids. It's not for like 2 years or 3 years. It's only for a few months. And that also in a tapering manner. So should not cause a big problem.
Yeah. So short course of steroid in the patient sugar is remaining around 200 or 180, 200, no need to treat. But if the patient is having simultaneously, as you said, some infection is there, candida is there, or something is there, then you have to use the topical drugs, or you can switch to be on safer side. the shortest acting insulin for a short period of time.
Okay. Thank you, sir. One more question. In patients with chronic kidney disease or acute kidney injury and without CECT, how do we diagnose the pancreatic SOL?
MR, you can do an MR.
Right.
First of all, if it is CKD on dialysis, you can do CT scan with contrast, because there is no point in not giving contrast in CKD with diabetes, number one. Number two, you can do MR instead of CT. And number three, you can still do EUS if you are suspecting.
Right. Thank you, sir. One more question. Pancreatic TB versus autoimmune pancreatitis. How to differentiate?
Yeah, pancreatic TB is rare. Normally, whatever we call pancreatic TB is not pancreatic TB. It's lymph node, which is by the side of pancreas, but it has compressed pancreas. So the margin between the pancreas and lymph node has become blurred. And you always think that it is pancreatic TB. Otherwise, pancreatic TB itself is very rare. Whatever we used to tell pancreatic TB are not pancreatic TB, they are lymph node TB. And it's a necrotic node. And so it's very well easily seen. And of course, pancreatic tumor also can have necrosis. So the final answer would be biopsy.
Right. Thank you, sir.
So if there are no questions, I would request Dr. Bhagirath Bhai to conclude the session.
Yeah. Thank you, Yogesh Bhai. Dr. Nilay Bhai have really, with the case-based approach, he has explained the usefulness of the CT and then we should not rely on CA 99/9 because he has shown all the reasons. And EUS also in the expert hand is going to be helpful. So this is really an eye-opener for the physicians that how to handle and probably early promptly diagnose, because Dr. Dhiren Bhai already told that because many a time the pancreatic malignancies are diagnosed very late and then the patient is not offered the appropriate treatment. So this was a very good learning for all the physicians. Thank you. Thank you, Nilay Bhai. Thank you, Yogesh Bhai. Thank you, Dr. Dhiren Bhai.
Thank you, sir.
Thank you, everyone.
Thank you.
Thank you, sir.
Thank you.